Brief therapy differs from other therapies in that it emphasizes on a specific problem and direct intervention. In brief therapy, the therapist takes responsibility for working more proactively with the client in order to treat clinical and subjective conditions faster. It also emphasizes precise observations, utilization of natural resources, and temporary suspension of disbelief to consider new perspectives and multiple viewpoints. Brief therapy is often highly strategic, exploratory, and solution-based, rather than the problem-oriented. It is less concerned with how a problem arose than with the current factors that are preventing change. Brief therapists do not adhere to one correct approach, but rather accept that there are many paths, any of which may or may not turn out to be ultimately beneficial. Milton Erickson was born December 5, 1901, and grew up in Lowell, Wisconsin, in a modest farming family, and intended to become a farmer like his father. He was a late developer and was both dyslexic and colorblind. He overcame his dyslexia and had many other inspirations via a series of spontaneous auto-hypnotic flashes of light or creative moments, as described in the paper Auto-Hypnotic Experiences of Milton Erickson. At the age of 17, Erickson contracted polio and was so severely paralyzed that the doctors believed he would die. Erickson started watching people in his environment and soon learned that people could say no when they meant yes, and they could say yes and mean no at the same time. Erickson began studying nonverbal language and body language while lying paralyzed in bed. He had a baby sister who had begun to learn to creep and watched her as she grew from creeping to learning how to stand. Regaining the use of his arms, he completed a 200-mile canoe trip by himself. Erickson felt he could talk to the unconscious mind by disrupting the conscious mind temporarily and planting a verbal thought while the conscious mind was occupied. He accomplished this with a handshake or by touching the individual oddly so that the conscious mind would then become entranced. Neuro-linguistic programming and solution-focused brief therapy was developed from Erickson's brief therapy. Neuro-linguistic programming is an approach to communication, personal development, and psychotherapy created by Richard Bandler and John Grinder in California. Its creators claim a connection between the neurological process, language, and behavioral patterns learned through experience, and that these can be changed to achieve specific goals in life. Bandler and Grinder claim that neuro-linguistic programming methodology can model the skills of exceptional people, then those skills can be acquired by anyone. Bandler and Grinder also claimed that neuro-linguistic programming can treat problems such as phobias, depression, habit disorders, psychosomatic illnesses, allergies, common cold, and learning disorders, often in a single session. Neuro-linguistic programming has been adopted by some hypnotherapists and in seminars marketed to business and government. The balance of scientific evidence reveals neuro-linguistic programming to be a largely discredited pseudoscience. Scientific reviews show it contains numerous factual errors and fails to produce the results asserted by Bandler and Grinder. Solution-focused brief therapy has branched out numerous spectrums. Indeed, the approach is now known in other fields as simply solution-focused or solution-oriented therapy. Most notably, the field of addiction counseling has taken up solution-focused brief therapy as one of the most cost-effective means to treat problem drinking. Johns Hopkins University, the Center for Solution in Cando, North Dakota, and notable others have implemented solution-focused brief therapy as part of their program, where they use it as part of a partial hospitalization and in residential treatment facilities for both adolescents and adults. Solution-focused brief therapy is covered by most insurances, including Medicare. Medicare will pay for treatment of alcoholism and substance use disorders in both inpatient and outpatient settings. Medicare Part A pays for inpatient substance abuse treatment. Individuals will pay the same copay as for any other type of inpatient hospitalization. Likewise, Medicare Part B will pay for outpatient substance abuse treatment services from a clinic or hospital outpatient department.